This morning's 18th session of the Epilepsy Surgery Techniques meeting. We've got a really fascinating topic today and two of the world's experts on this topic. We're going to talk about optimizing seizure outcome in the management of low-grade glioma, particularly through the surgical management. And today we have Johan Pallud, who is the head of the Department of Neurosurgery at Hospital Sainte-Anne in Paris, and Eddie Chang, who is the chairman of neurosurgery at University of California, San Francisco. So Johan, first, if you could start and share your screen, that would be wonderful.
Okay, let's go. Everything is fine for you?
Yes, it is.
Okay, so let's go. First of all, I want to say that I'm very glad and happy to be here today with you, and I want to thank you for this kind invitation. Today, I will share my experience regarding the impact of surgical resection on the seizure control for diffuse low-grade glioma, and I will focus on the specific condition, the specific condition of diffuse low-grade glioma, and I will use my own experience and publication to support my talk. So no big deal here. And I will divide the talk in two parts. The first part will deal with the rationale to guide the surgical strategy for both oncological and epileptological purposes. Then, based on these findings, the second part will describe my own surgical technique, which is quite basic. Anatomical guidance using ultrasonography, functional guidance using intraoperative brain mapping under rare condition, and neurophysiological guidance using electrocorticography. Starting from my clinical practice, we know that diffuse low-grade glioma is a disabling disease with an increase of the frequency of epileptic seizures together with a decrease of the quality of life over time. And we know from pathological analysis that diffuse low-grade glioma disease is an infiltrative disease with no definite boundaries, and that isolated glioma cells infiltrate the brain parenchyma surrounding the tumoral core at both cortical and subcortical levels. And in addition, we know that isolated glioma cells are present behind MRI-defined abnormalities. In fact, MRI, whatever its modality, underestimates the spatial extent of diffuse low-grade glioma. And the example of the iceberg I refer here speaks by itself. Most of the tumor component is not visible on MRI. This has practical implications since MRI cannot be used as a guide to tailor the resection of diffuse low-grade glioma. Clinical practice highlights that diffuse glioma is a progressive disease with a systematic, constant, and continued growth before any oncological treatment. And quantitative analysis on MRI follow-up show an increase of about 4 mm per year of the mean tumor diameter over time. And in fact, a stable diffuse glioma does not exist. And this observation asks for an early surgical treatment for oncological purpose. Together with the tumor growth over time, we observe the high epileptogenicity of diffuse low-grade glioma. To the initial discovery of the tumor, until the end of life, we have a constant increase of the prevalence of epileptic seizures and an increase of drug resistance despite oncological treatments and despite anti-epileptic drug therapy. This is a common finding of diffuse low-grade glioma, from diffuse low-grade glioma on the left example to ADH wild-type glioblastoma in the right. And this observation asks for an early treatment for epileptological purpose too. To control for epileptic seizures, the question of the location of epileptic genic foci is of utmost importance. Using several approaches, both in humans and in animal models, we know that no epileptic activity arises from the glioma core, and that epileptic activity arises from the peritumoral cortex. To enhance this pivotal question, my group made neurophysiological recordings of human samples obtained within and outside glioma during surgical resection performed with functional brain mapping. These samples were maintained alive for a couple of hours under physiological conditions, and electrophysiological recordings were made. It allowed recording spontaneous interictal-like epileptiform discharges that you can identify in the example in the left, that were defined and identified as epileptic because they were nested with high-frequency oscillations, which are a hallmark of epileptic activity. The presence of this epileptogenic foci was correlated with the preoperative status of the patient. And in addition, they were correlated with the degree of glioma infiltration of the recorded samples. For example, they were recorded more frequently in samples obtained outside MRI-defined abnormality. They were recorded more frequently in samples with no macroscopic tumor infiltration and in samples with a high infiltration by isolated glioma cells. Contrarily, they were never recorded in control samples or within the tumor core. This observation implies that the neurosurgeon has to perform resection beyond MRI-defined abnormality for epileptological purpose to remove such epileptogenic foci. This observation is from a limited subset of patients, but it still stands when we study a large series of more 1,500 diffuse low-grade glioma from the French glioma study group. We identified two main parameters for the good postoperative seizure control. The first one is the time to oncological treatment. The shorter the time to treatment, the better the postoperative seizure control. The second parameter was the extent of surgical resection. The larger the resection, the better the postoperative seizure control. And to better analyze the impact of surgical resection on seizure control, we analyzed a subset of about 350 patients who all had preoperative seizures. And the question was what proportion of rare abnormalities must be removed to achieve seizure control postoperatively, which means a patient without any seizures with a mean angle when high. And we observed a linearity between the extent of resection and postoperative seizure control. In the histogram, we have on the left patient with less than 50% of resection of flare abnormality to 100% of resection. And we observed a reduction of uncontrolled seizures that are highlighted in red, together with an increase of controlled seizures that are highlighted in blue, with the increase of the extent of resection. And similarly, the amount of patients with postoperative seizure control plus without any anti-epileptic drug therapy, as you can see here in purple, increases with the extent of resection. In the same series, we identify an extent of resection threshold of more than 91% and a threshold of residual tumor of less than 19 cubic centimeters to achieve a good seizure control postoperatively. So, based from this observation from clinical practice, we can now propose the following practical message for the neurosurgical community. Because glioma and seizure share common underlying mechanism, it explains the impact of treatments on both seizures and glioma. Second, glioma and seizure both progress with time, which asks for an early treatment. Then both oncological and epileptological prognosis are linked to the extent of resection, which asks for a maximal resection. And because glioma cells and epileptogenic foci are located outside beyond MRI-defined abnormalities, it asks for a maximal function-based resection. And very basically, in fact, in front of a diffuse low-grade glioma present with epileptic seizures, you have the same unique goal, which is the early and maximal function-based resection for both oncological and epileptological purposes. So, this being said, we will see now I try to perform such a maximal function-based resection. In my institution, for more than 10 years, I perform function-based resection using intraoperative brain mapping with direct electrical stimulation under awake condition. I use the Hodgman parameters. And I envision direct electrical stimulation, not to highlight a particular eloquent brain area, but to interact with a part of a large subcortical and cortico-subcortical networks. This has two implications. The first one is that the cortical mapping must be performed together with the subsequent subcortical mapping. Second is that the real-time functional mapping requires the patient to be awake. And we perform the classical asleep, awake, asleep protocol. And we awake the patient during the opening of the dura mater. Then, when the patient is fully awake, we perform the initial cortical mapping, and the patient still works during the tumor resection to identify and tailor the deep functional boundaries of resection. Then, the resection can be completed in non-eloquent area where the patient is asleep. Such a resection when the patient is awake implies a clear definition of the surgical strategy. We have limited duration of about 90 minutes with the patient fully efficient to perform testing, as the strategy must be adapted as follows. You must attack first part of the tumor that are close to eloquent areas and that requires cortical and subcortical mapping. And after, you can achieve the resection in non-eloquent areas at the end of the procedure in a sleep patient. Such a surgical strategy is defined preoperatively by the neurosurgeon and with the patient. And the resection borders are defined according to eloquent cortical and subcortical boundaries, according to areas at risk of vascular damages, and according to goals defined preoperatively with the patient. For example, the resection of the preservation of premotor networks. Rarely in clinical practice, the resection is stopped before the identification of the planned limit of resection, mostly due to the patient fatigues, and the patient is unable to pursue neurocognitive tests. From the beginning of my practice, I do awake surgery with a friend of colleague of mine, who is Edouard Zami, and this is a real forehand surgical technique. We are two neurosurgeons. The first neurosurgeon is in charge of the tumor removal with the CUSA and a suction. The second neurosurgeon is in charge of the anatomy with the retractor and stimulator. This is the way we perform awake surgeries with permanent direct electrical stimulation throughout resection to maximize the function mapping. This is very convenient, and in fact, the only difficulty is that you have to be in perfect agreement with your colleague, trust each other, and know each other. Of course, this forehand technique induces a very high number of direct electrical stimulation, and it can be a concern regarding intraoperative and early postoperative seizures. In our experience, despite repeated electrical stimulation, intraoperative seizures occur in 3.5% of cases. All resolve with skull ringer, and none require the abortion of the procedure. Early postoperative seizures occur in about 8% of cases. And one of the predictors of the occurrence of early postoperative seizure is the intensity of the current used for mapping. So it is mandatory to use the lowest current intensity to map your patient. This being said, we can routinely tailor the resection according to functional boundaries, such as primary motor pathways, as observed in this example. You for sure can map primary sensory pathways.
Index.
Bravo. Quelque chose?
Tous les doigts là. Tous les doigts.
Non, sauf le pouce.
Tous les doigts sauf le pouce.
Okay, sorry, for sure in this example, the patient will speak in French, but the patient here explain he has paresthesia in the index, then paresthesia in all fingers but the thumb. To map language pathway, we perform mainly picture naming tasks. And in this example of a large left frontal insular diffuse glioma, we limited the resection up to the dorsal phonologic pathway, which was identified by the observation of phonemic paraphasia in the upper depth of the cavity. And we limited the resection up to the ventral semantic pathway with the observation of semantic paraphasia in the lower and inner depth of the surgical cavity. In addition, premotor pathways can be mapped using voluntary movement task. And in addition, we map non-verbal segmented cognition and emotion task. In this example of a right insular diffuse low-grade glioma, the resection has been tailored according to premotor pathways and according to the identification of the inferior frontal occipital fasciculus, identified in this case with the observation in error in non-verbal recognition task using the pyramid and pound tree test. Now let's focus on a particular illustrative case. This is a 20-year-old woman without past medical history who present with focal seizures that are controlled under one anti-epileptic drug. Following preoperative workup, we identified this left diffuse glioma invading the superior frontal gyrus. We plan a maximal function-based resection under awake condition, and after discussions with the patient, we decided to tailor the resection posteriorly up to the premotor pathways and laterally up to the language pathways. Here is the result of the initial cortical mapping in the silence in front of the projection of the tumor. In 10 and 12, we observed speech arrest, which served to define the threshold of all current stimulation.
1, 2, 3. Arrête. Avec, j'ai de la déglutition.
Then we identified a primary motor pathway on the face in 1, the upper limb in 2 and 3.
Alors, fasciculation de la mâchoire, déviation de la mâchoire, clomie et déviation de la langue.
Ok.
Serrage du poing, pliage du coude.
And primary motor cortex was identified by provoking involuntary movements. And in addition to primary motor cortex, we identified, we made the primary motor cortex. Now we mapped the premotor cortical networks that are present in 5 and 4 by a voluntary movement task.
Alors, déviation du coude.
Which stimulation induced an arrest of the voluntary movement. Then, to ensure the quality of the cortical mapping, we verify the presence of paresthesia on the upper limb in 2021, on the lips in 22, and on the tongue in 23.
Quelque chose?
Oui, fourmillement au niveau de l'index droit.
D'accord.
The patient said she had paresthesia in the right index.
Quelque chose?
Fourmillement au niveau de la lèvre droite supérieure.
She said she had paresthesia in the right upper lip.
Quelque chose?
Fourmillement au niveau de la langue droite.
D'accord.
She said she had paresthesia in the right part of the tongue. And after this initial mapping, the resection begins, and it is performed with continuous testing, including a picture naming task plus a voluntary movement task. The first step of the resection is the identification of functional boundaries. And I identified first the posterior limits of resection, and the posterior resection is performed until provoking arrests in voluntary movement while stimulating the premotor pathways. Then I continue and I identify the lateral limits of resection, and the resection is performed laterally until provoking difficulties in picture naming tasks, or that allowed us to identify the superior frontal fasciculus, the superior longitudinal fasciculus laterally, and the limits with premotor pathways posterior. The last part of the resection is the identification and the definition of the deep internal and anterior boundaries that are anatomical. A debulking is performed according to the eloquent boundaries we identified first, and then we perform a subpar resection until the corpus callosum, and lastly, the resection of the anterior part of the lesion is performed when the patient is asleep. Here is a picture of the surgical field at the end of the resection, as the resection has been tailored according to the functional boundaries we define preoperatively. The superior longitudinal fasciculus laterally is identified by phonemic disturbances in 15.
Ça, c'est un pied. Ouais. Ça, c'est une arrêt, ébauche phonémique qui aboutit.
And most posteriorly, the premotor pathways are identified, and they are identified by the speech latency only in 13 and 14.
J'ai une latence qui aboutit.
By heniomia plus arrest of the movement here.
Blocage.
Ouais,
Mais du langage, il n'est pas moteur.
In this stimulation, the patient was able to make voluntary movement, but she has a real heniomia because she said, this is up, but no more. And in the last part, anatria plus movement on the rest.
Oui. Arrêt du mouvement, latence, le mouvement repris. J'ai une latence qui n'aboutit pas.
And to close this case, the histomolecular diagnosis was a HGH mutated 1p19q codylated grade 3 oligodendroglioma. On the right part, you can see the 1 year post-op MRI, which is unusual, quite difficult to analyze, but it demonstrates resection beyond abnormalities visible on preoperative MRI. No oncological treatment has been administered in this young patient with a complete removal. And at 1 year of post-operative follow-up, the patient is seizure-free. She has no anti-epileptic therapy. She works full-time, but she's still under cognitive rehabilitation. In addition to the intraoperative functional brain mapping, I use intraoperative corticography, but this is a routine use during functional mapping because it helps me identify rare focal seizures or post-discharges following direct electrical stimulation. But I do not use these neurophysiological recordings to identify epileptogenic foci. Why? Because I think it is not accurate enough. It is difficult to obtain useful information from live analysis performed by the neurophysiologist, and I think that the value of the observed event on a only qualitative basis is questionable. On the right, you can see an example of the observed event in the wall exposed cortex with change we observe and that are most induced by the tumor himself. This being said, I'm sure that intraoperative neurophysiological recordings are very important, and we try to improve our neurophysiological tools and analysis. First, we try to improve the data acquisition with new electrodes that offer a better spatial resolution and a better signal-to-noise ratio. And we hope with such a device to be able to record high-frequency oscillations. In addition, we are trying to develop neurophysiological biomarker of epileptogenicity, including the live and real-time identification of high-frequency oscillation. And we try now to compare these neurophysiological findings with the neuropathological findings obtained from the brain sample we analyze. And we aim at obtaining a neurophysiological biomarker of such epileptogenic foci. This will allow us to detect indirectly by the presence of isolated glioma cells by a neurophysiological signature. Here, another link between seizure and glioma, and we will track and remove glioma cells while guided by neurophysiological change they induce. And to conclude this talk with the take-home message, we know that both glioma and seizure progress with time. Both oncological and epileptological prognosis are linked to the extent of resection, and we know that glioma cells and epileptogenic foci extend beyond MRI-defined abnormalities. And as a consequence, for a neurosurgeon, I recommend early or maximum function-based resection for diffuse glioma for both oncological and epileptological purposes. So that's all for me. I thank you for your attention.
Thank you so much, Johan. If you could unshare your screen, that would be great. Our next speaker is Eddie Chang. Eddie is the professor and chairman of neurosurgery at the University of California, San Francisco, which, as everyone knows, Eddie trained under Mitch Berger and has now taken over as chair of that program. And so he is going to talk to us about the UCSF perspective on achieving seizure freedom in low-grade glioma surgery. Thank you, Eddie, so much for being here this morning.
Guy, thanks so much. Thanks for the other organizers. It's wonderful to be with you. Yeah, so as Guy alluded to, a lot of this is a reflection of 2 decades worth of experience that I've had under mentorship of Dr. Berger and now in my own practice in thinking about low-grade glioma. My perspective is a little bit, I think, very, very similar with the previous presentation, except that there's probably a little bit more emphasis on the epilepsy because my primary focus is on epilepsy surgery, though I do take care of a lot of patients with low-grade glioma as well. These statistics are very important. I think epilepsy control in low-grade glioma is particularly important. This has been known for decades now, many years. It's been known that low-grade glioma has a much higher rate of association with epilepsy compared to other gliomas. About 80 to 90% of low-grade glioma patients will present with seizures. And it seemed that, maybe 20 years ago, it was really two different worlds, the oncologic world and the seizure outcomes world, thinking about these 2 really different things. The oncologic world was really thinking about seizures as symptoms and diagnostic parameters, but not really anything that was influencing quality of life or endpoints for surgery. So Mitch and I did this study. In fact, when I was a resident in training with him, we started looking at outcomes in patients that were having uncontrolled seizures and controlled ones in the setting of low-grade gliomas. This is one of the first large series, and the things that you'll see in this partitioning of patients of 332 patients was that gross total resection was by far more strongly associated with seizure-free outcome compared to subtotal resection. And then some other things like longer history of seizure history and simple partial seizures tended to be associated with uncontrolled seizures. So this is an important starting point for us in thinking about outcomes. And when we look at some of the numbers, these are factors. These are 3 particular factors from a multivariate analysis that predicts seizure freedom. But you see that the extent of resection is extremely important in terms of obtaining seizure control outcomes, the odds ratio of 16. So a patient was 16 times more likely to have seizure control with a gross total resection on imaging compared to a subtotal resection, where some of the other variables were important, but not nearly as important. Another thing that's important in this paper that we found, many of you will see this, is that after initial surgery, someone may be seizure-free, but then maybe a couple of years down the line will have a seizure recurrence. And what we found in this study, when you looked at those patients that were initially seizure-free after resection, we found that patients that had a seizure recurrence oftentimes was a harbinger or a clue that the tumor progression was occurring. In fact, when patients came back for surgery, it was documented histologically with tumor progression. So in the setting of low-grade gliomas, where their patients are initially seizure-free, seizure recurrence is correlated with tumor progression. So we looked at this in meta-analysis later, and this was validated from multiple studies around the world. 20 published studies were included in this meta-analysis in 2011, and there's been a lot of work on this that has, again, validated this kind of approach. And then at the same time, I think, nowadays it seems like it's primarily accepted, but really only about 15 to 20 years ago, the role of extent of resection was very, very controversial, and Mitch Berger played a huge role in defining the important outcomes related to survival benefit, which is where most of the emphasis was looking at survival benefit in patients with low-grade glioma, or what's been called as the oncologic benefit. And here it's also very clear that extent of resection is associated with a much higher long-term survival. So the take home, and this is very similar to what Dr. Pallud has alluded to, is that extent of resection is important both for tumor control and seizure control. These are two directly related things. And in fact, when you look at patients and their quality of life after tumor surgery for low-grade gliomas, the use of anticonvulsants and ongoing seizures is the #1 predictor of quality of life. That is, patients that have seizure control are the ones that have the best quality of life after surgery, and the ones that don't are the ones that have worse quality of life. So gross total resection in terms of tumor control at 10-year survival is 95 to 100%. Gross total resection in terms of seizure control, we now know seizure freedom is about 85 to 90%. So these are very similar numbers and are directly related. Subtotal resections are much, much lower. So in each one of these cases, we're really thinking about how to get good oncologic control in seizures. They are directly related. So I just wanted to focus on a couple of cases, since this is really a focus on the operative approach and how do we achieve both oncologic and seizure control outcomes. This is a case that I think is very similar to many patients who treat brain tumors and also epilepsy. A young man, 24 years old, right-handed, with spells for several years associated with fatigue, deja vu, metallic taste, left-sided tingling, hot feeling on the right, on the upper arm, and then had a severe motor vehicle crash during one of these associated loss of consciousness blackout events. He's had progressive word-finding difficulties, which at age 24 is very unusual, and has persistent seizures despite being on multiple anticonvulsants. So his imaging showed basically a amygdala-based lesion, pretty subtle here, but you can see that the amygdala part of the medial temporal lobe is slightly expanded. And one of the key questions here, of course, is the extent of resection in medial temporal lobe lesions, in particular when it's associated with just the hippocampus or the amygdala alone. The question is, how much should you remove? And this is where intraoperative electrocorticography is very helpful. We still use one of the old style crown arrays, primarily for economic reasons. These are much easier to sterilize and reuse without the costs of putting strip electrodes, which are disposable. So because of the very, very high volume of cases that we do with intraoperative electrocorticography basically every day, this has been a very good and reliable way for us to perform intraop ECOG, along with some depth electrodes, as you can see here as well. So pre-resection intraoperative electrocorticography from multiple areas, from the lateral, frontal, and temporal regions, as well as from the amygdala and hippocampus. And in this particular case, it this time looked pretty benign. So we resected the lateral component of the temporal lobe and placed a strip electrode over the hippocampus. Dr. McCann and Dr. Ochman had really spearheaded this kind of approach for mesial temporal lobe epilepsy and defining extent of resection for the hippocampus. And this was primarily used to help define the extent of resection of the hippocampus, even though it had no imaging abnormalities. The question is, should we remove the dominant temporal lobe hippocampus in the amygdala alone? And in this particular case, we proceeded to do that because there were epileptiform interictal discharges from the hippocampus that led to resection of that. And this is from a strip electrode placed in the temporal horn. Final pathology was a ganglioglioma, though this is a very common situation that many people will see in the setting of amygdalar low-grade glioma. This is a different case that I think is very similar to the ones I presented previously. This is one that I saw just last week. It was convenient to include in this. But some new principles. 34-year-old right-handed woman who presented with very, very frequent focal motor seizures involving the right face pulling and occasionally speech arrest, and then also developed progressive facial weakness, House-Brackman 2. So from this history, you are suspecting something very close to the rhodopsin cortex. And I want to just describe sort of like the approach to tumors in this region. We'll look at the MRI in a second, but to just describe the intraoperative approach that we're using right now. One is intraoperative electrocorticography to find the perilesional interictal spiking. Number 2 is neuronavigation. In this particular case, I use it in these highly, highly eloquent areas to place intraoperative landmarks with a navigated stylet. So that's one of the main reasons I use the neuronavigation. In addition to localizing the boundaries, is to actually place interparenchymal landmarks in order to adjust for shift. Third is ultrasound, and fourth is awake mapping and monitoring whenever possible for bipolar stimulation for language and motor mapping from the cortex, and then monopolar stimulation for subcortical motor mapping. So this is the standard approach that I use in patients that have low-grade glioma associated with seizures. So this is the young woman that we took care of last week. She came from out of state and was having these progressive seizures. And this is basically occupying the precentral gyrus. The precentral gyrus is expanded, and you can see that there's some really critical anatomy. The posterior boundary is the Rolandic cortex and postcentral gyrus. Medially, you have the cortical spinal tract coming from the dorsal hand area, and then below it in front of it are language areas that are associated with syntax and more. This is a coronal. So again, hand area is expected to be dorsal to this lesion. Cortical spinal tract for leg and hand would run medial to this, and then face and language areas anterior and inferior. Posterior, you would have Rolandic cortex. This one is primarily based in the middle frontal gyrus and a little bit in the inferior. Here's some of the diffusion tensor imaging to look at the language and motor tracts. You can see that the lesion is pushing down the arcufaciculus or the superior longitudinal fasciculus, and the cortical spinal tract is very hard to actually image through the lesion because of the artifacts from the lesion itself. But there are some residual fibers that are posterior and then also medial to the tumor that carry information from the hand and leg areas to the spinal cord. This is an image I have from Mitch's slide deck, which is essentially using intraop brain mapping to identify the areas that are important for motor or sensory, face, and arm, as well as speech arrest. And here's what we found. So 1 and 2 and 3 correspond to, and this is during the awake mapping. 1, 2, and 3 correspond to hand and forearm localization. A is speech arrest, and everything that you see behind this is related to the postcentral gyrus. So sensory paresthesias for the hand, face tingling and tongue tingling, as well as some of that down below. The orientation is that this is superior, just in the surgeon's view. So this is the side that is closest to us, and the ventral is down on the other side, just for orientation, in a very large trolar that runs primarily along the central sulcus in this particular case. Now, I also want to point your attention to a couple of intraoperative landmarks or fiducials that I use on cases that it's absolutely critical in order to know the boundaries. So in this particular case, I use a navigated stylet to put a fiducial on the upper limits of the tumor, between the tumor and the hand motor cortex, so that I have some anatomic landmark before the resection debulking happens. in order to verify the boundaries and not get into the hand cortex. A posterior-based landmark so that it doesn't get into the posterior postcentral gyrus. As many of you know, the postcentral gyrus actually does have motor fibers in it as well. And so preservation of those sensory fibers when you're removing the motor cortex, for example, is very important for postoperative recovery. And also a landmark in the middle of the tumor that goes to the depth of the tumor, and the depth can be measured preoperatively and then also measured with the catheter that has measurements on it so that you know exactly what depth you need to stop without having to rely necessarily on navigation or stimulation mapping, which I will describe we also use. Now, the tumor outline in this particular case is essentially here on the neuronavigation. And the challenge with this particular case was how to approach this with a speech arrest site actually right in the middle of the tumor, a very reproducible speech arrest in the center of the approach. Again, using some intraoperative electrocorticography to define it, this was not particularly useful in this case. Another important adjunct is the use of intraoperative ultrasound for low-grade gliomas in particular. And you can see here that having this, which can be navigated now with the brain lab, gives you a very nice delineation of the central sulcus and the postcentral gyrus behind it, which is normal. But the primary reason I use this is to define the depth of the tumor and to some degree of the lateral boundaries. A second reason that I like using ultrasound is to define the vascular flow around the tumor and to be able to anticipate it before actually resection. And so it's very helpful actually to use the Doppler ultrasound to understand the blood flow to the tumor and where you're expecting vascularity. And in this particular case, you can see that the feeders to the central sulcus, which are embedded deep down in the central sulcus, are actually ones that are going inside the tumor as well. And that's a very useful tool that I always look at before starting resection as well. So it's a vascular imaging to image that. So going back to this question, what do you do essentially when you've got something like speech arrest, quote unquote eloquent defining language area that is important for function? And I've seen this several times now. It's always a very difficult situation. But what I did in this particular case was I identified that this area was important for speech arrest. And I never removed this until I start, in many cases, you try to start in the middle of the tumor and move quickly towards the most eloquent areas while the patient is awake and under monitoring. In this particular case, because this was identified with speech arrest, I actually started the resection as anterior as possible and slowly shaved the tumor millimeter by millimeter as I approached this area while the patient was engaged in repetition naming tasks. So that's a very important aspect of not just mapping, but doing monitoring during the resection. And what I found was that as we got closer, the patient did not actually have a decrement in speaking ability. And in fact, we went right through the speech arrest area to define and resect all of this area. So therefore, removing the speech arrest area in order to remove the tumor. And that's something I've had to do several times now, and is always difficult to do because you're very hardwired to not do that. But speech arrest areas can be removed. But in general, I recommend that you do it very carefully and don't remove that site first. Work towards it from an area that's defined to be non-eloquent so that you can stop if necessary. But in every case that I've needed to remove it, I've actually been able to remove it. And this definitely raises some question about what the role of those speech arrest findings are. There's new work from our lab that suggests that speech arrest is not actually a good surrogate for Broca's area at all, and involved in inhibition of speech, which is something very different than people have thought about in its role in terms of motor planning. So could be a totally different function that we've misinterpreted all along. So this is essentially after resection, and one of the reasons I'm showing this is actually a suction I want to point out that oftentimes we'll use subcortical motor mapping, and in this particular case, the subcortical motor mapping is very, very important because the cortical spinal tract is immediately medial to the tumor. And at the medial boundaries, I obtained about 0.5 to 1 milliamp, which corresponds to 1 millimeter distance from the cortical spinal tract, especially posterior in this tumor. So using monopolar subcortical motor mapping and stimulation is very important. It has a dose-dependent relationship with distance to the cortical spinal tract. And so when you get down to anywhere around 2 milliamps, we typically stop. And this can be very, very sensitive in someone who's awake using EMG sticker pads. So this is the resection, again, moving through the speech arrest area. And ultrasound is also used. Again, you just fill the cavity with fluid and you can see that you have the inferior extent of resection as well as the boundaries. And post-MRI shows the gross total resection, again, with care to protect the cortical spinal tract, posterior rolandic cortex, and language areas below. So just to conclude, here are some of my thinking or my thoughts about tumor-related epilepsy, especially as it relates to low-grade glioma. I think for most epilepsy surgeons, it's much, much more straightforward than non-lesional epilepsy surgery. You basically know where the epilepsy focuses to a large degree that can be tailored with intraoperative electrocorticography. So these typically don't require any kind of extraoperative mapping or invasive electrodes. Subtotal versus gross total resection is critical for seizure freedom and long-term control. My philosophical perspective is that epilepsy surgery approach is much, much more appropriate than the basic tumor approach. And primarily because many of these tools were developed for epilepsy. The awake mapping was originally developed in epilepsy surgery. Is really important for functional mapping, familiarity with intraoperative electrocorticography, another standard tool in epilepsy surgery. And I also believe that anatomic approach to these lesions is better when possible, especially when you're dealing with things like the medial temporal lobe anatomy. A large number of cases I see are subtotal or near total resections of medial temporal lobe tumors, but patient has significant ongoing seizures that could have been definitively addressed with an epilepsy surgery approach. With that, epilepsy surgery approach also is a much, much more involved in deep consideration of the risks of the surgery, including memory and eloquence, and complete neuropsychological evaluation, which is standard in epilepsy surgery, but not so much in tumor. A lot of time has been spent previously on pathology and whether it matters. From my perspective, not really. I don't think about it too much. The outcomes are nearly the same across low-grade glioma and glial neuronal tumors like DNET and ganglioglioma. The approach that I've outlined here is largely similar for all of these low-grade tumors. So I want to thank everyone in the course organizers for allowing me to participate in this really wonderful global symposium. Thank you very much.
Thanks, Eddie, for that wonderful talk. If any of the attendees have questions, please add them to the Q&A area and we can try to get to them. We've got some time for discussion now. I know we've got multiple questions. I'll start out with a question for both of you, which is that when you're deciding and pushing the limits of a resection, oftentimes you'll get to a point where a patient starts to have a deficit and you have to decide at what point do you stop and what is a recoverable deficit. And so how do you each make that decision, both in terms of language function as well as motor function? When somebody starts to have a deficit, at what point do you say, okay, this is a safe amount of deficit that the patient can recover with rehab versus this is where I have to stop?
Eddie first, or I can?
Go ahead, Johan. Go ahead first.
Sure.
Yeah.
So in my practice, often before the appearance of a deficit, you have slight disturbances induced by your stimulation or by your cue. And usually I stop before the appearance of a deficit. And if I'm not sure, because I am in the depth close, for example, to the pyramidal pathways, I increase the intensity of my current to have an idea of the depth of the pyramidal tracts in millimeters. If I have anything at 2 milliamps, I increase to 3 to 4 to 5. And if I have a deficit, I know that I'm quite far. But usually I stop before the observation of a deficit.
Yeah, just to add to that, you know, with pyramidal motor, basically, I'll stop immediately if I have a sense and it's verified with the physiology. With language, well, let me just clarify that. With pyramidal leg and arm, within 2 milliamps, we'll basically stop with the subcortical mapping. If someone has weakness in the setting of a lesion in the SMA, I will rely much more on the monopolar subcortical mapping than intraoperative monitoring. I've definitely seen cases where people develop SMA during the resection, and that's not reliable, basically. And so having a strip electrode over the motor cortex and then also using subcortical monopolar is going to be much more definitive in terms of predicting outcomes. In terms of face motor, I'll oftentimes just resect until someone, and we'll document when someone becomes weak in the face, but we'll continue to resect even in the setting of a weak face, because that recovers usually in 2 to 3 weeks.
And can you, Eddie, you were talking about the issue of language testing, and can you comment, both of you, on the difference between speech arrest versus paraphasic errors and language disturbance in mapping, and how you look at that? Because again, you showed a case with a speech arrest, and there's some controversy in the literature and what people say in talks about what you can resect in terms of dominant face motor versus dominant speech arrest versus an area that's truly a language paraphasic error.
Yeah, I mean, I think it's provocative for sure. For over a century, we've
Hold on 1 second, Eddie. We lost you for 1 sec.
I'm just saying that rest.
I think there's something wrong with your connection, Eddie.
Yeah, we didn't get you.
Yeah.
Yeah, I'm gonna try to answer. In my experience, I respect the eloquent areas, and if I observe a speech arrest area, I won't remove it, whatever the degree of infiltration within this area.
Yeah, Eddie, can you repeat your answer? Because I don't think we got it.
Okay, yeah, just to repeat, I think that this is provocative and something I think that's very hard to do, which is to remove speech arrest area. But there's a couple of reasons why I think it's feasible and why we've probably been misinterpreting the role of speech arrest area. So number one is that you can get speech arrest from multiple areas that have nothing to do with Broca's area. You can see it when you stimulate in awake patients in the precentral gyrus as well as the pars opercularis in the non-dominant hemisphere. So you can see speech arrest on the right hemisphere as well as the left hemisphere, and in both sides, it can be removed. You can also see speech arrest when you stimulate in areas that aren't involved with motor directly at all and can be resected in areas like the SMA. So there are multiple examples of areas that you can induce speech arrest that can be removed. The one that, of course, that is the most, I guess theoretically challenging is the one that is in the pars opercularis and precentral gyrus on the dominant hemisphere. But the case that I just showed you was one that, again, I've added to my series now where we've been able to remove that without patients having any, severe change in language. And again, I never removed that spot up front in the resection. I work towards it millimeter by millimeter. And if the tumor is infiltrating, I will try to remove it if possible. If the tumor is not infiltrating, I'll definitely try to protect it. I definitely won't go looking for that. But if the tumor is infiltrating it, in order to achieve the gross total resection and seizure outcomes, the speech arrest area can be removed under certain conditions.
I think that Bertil had questions for both of you, and then Jorge has a hand up. So Bertil?
Yeah. First, I have a question for you, Johan, and then I have a comment for you, Eddie. My question to you, Johan, is that before I say anything, I say that I usually don't operate low-grade glioma because we have extremely devoted colleagues at my hospital who really perform that type of surgery. But I was a little bit surprised about your case of the superior frontal gyrus, because I reflect upon the superior frontal gyrus as a, even on the dominant side, as a region where you have a lot of surgical freedom. Of course, I have operated quite a few with displacement and frontal superior gyrus, not so much low-grade glioma, and you have an immense amount of surgical freedom. So I would have done that as an anesthetized patient. So I would like to comment on that. And then before you reply, I will also have a comment to Eddie. Eddie, I really appreciate your comment upon the anatomical circumstances. I think the anatomy is as we say in Sweden, as we say in English, or what. If you have an anatomical compartment, I think it's so important to keep into that anatomical compartment. So please, Johan, would you please comment on my question?
Sorry. Thank you for your comment. So yes, you say that anatomy is really important, and I try to follow it based on anatomical landmarks, as Eddie showed using ultrasonography, plus anatomical landmarks offered by intraoperative monitoring. And this is a mix of anatomical anatomy plus functional anatomy that allows me to guide my resection. I took this example because it was quite instructive, but it's in other cases is less easy to have clear and large boundaries outside the brain tumor has visible on MRI.
Yeah, it was an extremely interesting case, I must say. I was just wondering a little bit about the borders, because I probably, if I would have operated that patient, I would have been much more pragmatic and just remove it, since it was the superior frontal gyrus, even on the dominant side. And if you operate in the superior frontal gyrus, it's extremely easy, I must say, to find the anatomical boundary for the primary motor cortex. But thank you so much for this patient example. It's very important.
Thank you.
You're mute, guy.
Yeah, Jorge, you have a question?
Sure, I have a question. I just want to thank you, Ed and Johan, for great presentations. I have a question specifically for case 2, for Ed, and a question for both speakers. So Ed, I understand in your case 2, you have a lesion on the amygdala, and you did intraoperative, and then you found spikes on the hippocampus, and we took the hippocampus as well, correct?
Correct.
So my question is the following. We see interdictory spikes very frequently in the hippocampus in the scenario of mesial temporal lobe lesions, specifically temporal pole and amygdala. And we know that those interdictory spikes are not associated with epileptogenicity when we perform extraoperative mapping. So my specific question for you and for Johan is, what is the role of extraoperative mapping and ictal recordings of seizures to tailor resections, lesional resections based on tumors in temporal lobe epilepsies. I would probably defer a little bit of your approach for that case, because we see very frequently interdictory spikes in the hippocampus, and it does not to us represent a reason to remove the hippocampus, because those are just interdictory spikes. It's part of the irritative zone. So I just want to know what is, if you ever do extraoperative mapping to tailor the resections in lesional tumor-based cases, and also to Johan coming from Santan, do you guys ever use SEG to tailor the resection in those cases?
And I think, could you both comment specifically on the case you showed, Eddie, which was an amygdala lesion, and was that the dominant hemisphere in this patient, and what was the neuropsychological consequences of that more extensive removal?
Yeah, it's a really, really good question, and I think it's a very good question. In these kind of settings, it's very rare for us to use stereo. So 50% or 75% now, I think, of my practice stereo EEG based. But we would rarely do any kind of electrode implantation to do kind of localization. We know the amygdala is going to come out. The question is really the hippocampus. And you're absolutely right, Jorge, that it's very, very common to see interictal spiking from the hippocampus. I think the question is even though it may not be the onset of the seizure in that particular time, the question is, what is going to be the outcome years later vis-a-vis the risks of removing that posterior hippocampal body and tail? And it's not really about, is that the onset? It's like, does that have potential to become later part of the epilepsy? And I think that to me is the more important thing. It's not necessarily that it's the onset, but it's potential for downline. And so in our practice, we tend to use the intraop ECOG in the interictal spiking to give us a predictor of seizure control. We talk about it with the patients that is an option. It's not one that we have to use during the surgery. You know, we could always leave it just a lesion. And if the risk is very, very high based on the neuropsych testing, then we may ignore seeing interictal spiking there, but at least document it for the future. And someone who's already having word finding difficulty, the neuropsych is essentially telling us that he's not going to have a huge risk to some of his naming and memory by going after the hippocampus. He's already had that hiss. So as you know, the neuropsych testing before the surgery is very important to predict what the outcome is going to be after. If they already have compromised neuropsych testing, then we will be a lot more aggressive with the use of the intraop electrocardiography to remove all interictal spiking that we see.
So Johan, as Jorge was saying, you know, you are the chair at the home of stereo EEG, one of the main places where stereo EEG originated. In what circumstances do you use stereo EEG in glioma patients?
Very important question. I focused my talk on diffuse low-grade glioma, means at least grade 2 or grade 3. So for such patients, we do not know the exact history of the disease, and we do not have so much time, and we perform surgery 1 to 3 months after discovery. So we do not make an extensive workup. But for lower grade gliomas or glioneuronal tumors such as DNT or ganglioglioma, we have time, and we perform an extensive preoperative epileptological workup with colleagues, neurologists and epileptologists in the department. And we made for sure video EEG, metabolic analysis, and in addition, neuropsychological testing. And we made hypothesis of the location of epileptogenic foci and the epileptogenic zone. And we try to solve the question of what has to be removed, particularly in the temporal areas, removing or not the amygdala complex plus the hypocampal formation or not. And very rarely for such tumor, we perform a SEG because no, they are not long-standing history of epilepsy, so the epileptogenic networks are not so extensive. And for the specific question of diffuse low-grade gliomas in temporal areas, without visible infiltration of the hippocampal formation, for example, do I remove or not the hippocampal formation plus amygdala nuclei? I don't have an epileptologic workup for such patient, and I'm based on the experience of Hugh Dufaux. In cases of intractable epilepsy, I recommend the additional removal of the hippocampal formation, but if the patient have controlled seizures and if the hippocampal formation is not involved, I respect it.
I think it will be very interesting to see going forward how the field determines this particular utilization and application. You know, I would say for the case, Eddie, that you showed, we would absolutely now implant that patient with a short-term SEEG. Also to consider if there was just some hippocampal head involvement early in the seizures, we would potentially take out the very anterior part of the hippocampal head with the amygdala, preserve all the parahippocampal and entorhinal inputs and the hippocampus, the rest of it. But again, depending if the patient really has no neuropsychological risk, then you would do more. I think these are complicated, interesting questions that the field will figure out. But my prediction is we're going to see more centers actually doing maybe more monitoring in a situation like this, because it's so much safer now with SEEG than with subdurals. Christian, you had a
I mean, just to respond to that, I have a concern about that because these are pretty straightforward lesional cases, and you have a much bigger risk of under-operating or under-resecting in the theoretical concerns of the neuropsych outcome with under-resection and just going after the onset. That's a much bigger risk of having ongoing seizures, which in the long run is going to be the much bigger threat to the neuropsych outcomes. So I think that this is an important philosophical, difference about, how do you approach these? We have a different position right now, which is to really try to get the seizures under control, and that biases towards greater extent of resection on these.
Yeah, I think one thing though, I mean, that is really critical is what is the patient's neuropsychological status? Are they employed? How high functioning are they? Because if we extend a resection in a situation where somebody, I mean, it's very hard for a high functioning person. You can say, okay, you're going to have to make a list and write your words down. But I mean, they don't understand that until it happens. And the majority of them, and Arthur can comment on this in a minute, because I know he's written on this, is that when people have a functioning dominant hippocampus, it's very hard for patients to anticipate how life-altering that deficit might be. And so I think it's a very interesting area for discussion.
Yep.
Christian, I'm just going in order of the hands. Christian, you had your hand up before Arthur, and then Arthur.
I have a question with regard to the electrocardiography, specifically addressing monitoring for after discharge potentials. So in your practice, how often do you see after discharge potentials very distant to your stimulation site or very nearby? And how often do you feel that these after discharge potentials may mimic a functional loss where there is no functional loss from your stimulation site? Do you know what I mean?
Johan, do you want to go first?
Yeah. I observe rarely about 1 out 100 stimulation, but because we perform hundreds of stimulation during surgery, we observe it finally quite often. I didn't have accurate and quantitative data, but my thought is that they are not systematically close to the site of stimulation. They're sometimes quite far. And sometimes they are correlated, but not systematically, with a disturbance of the clinical response of the patient. So to ensure the quality of the mapping, I systematically repeat my test, and I consider a site as eloquent for a particular function if I have at least 3 same disturbances observed in 3 different stimulations without after discharges. And That's my experience.
So you would say it's absolutely of value to use it, because there are people that are don't using electrocorticography for after discharge potential. So in your opinion, your practice, it's absolutely of value to use it.
No, that's not mandatory. I use it because I have the device, but if I, for a particular reason, not an access to electrocorticography, I can't perform my surgery, and with the same observations that at least 3 disturbances to define an eloquent site, I do not have difficulties with false positive or false negative observation. So that's an additional tool which is very convenient, but that's not necessary to my point of view.
I want to just add to that. I think it's not critical, but when it is available, there's 2 reasons. One is that if someone is developing a focal seizure, you can see it pretty quickly before it's like convulsive. And when patients are awake and having convulsive seizure, that's very dangerous and has to be avoided, as much as possible. So requested for all cases. And then the second thing is that there's 2 other reasons. One is the interpretation. When you've got a question about.
We're losing you again, Eddie.
Moving up, talking.
Hey, Eddie, we lost you again.
I have a comment which I could take meanwhile.
Can we
Are you back, Eddie?
Oh yeah, I'm back. Sorry, I just gave
Right.
up. Yeah, no. Basically, the last reason is just when someone stops speaking, for example. It's very helpful to know if it's after discharges or for that. And then the third is actually understanding, how high you can go on the current stimulation. If you're not seeing something, but you really expect to see it, let's say over the motor cortex, it's really helpful to have the ECOG to help define what that threshold is.
Arthur, I think you had your hand up next.
Okay. Oh, thank you so much, Johan and Eddie, for such nice presentations. Just brief comments and maybe 1 or 2 questions. I believe that in real life, what is very difficult nowadays to get refractory epilepsies with low-grade gliomas, because they have the first seizure and they're scanned in the emergency room, and then they go very frequently for treatment. And then I just wonder what kind of value would you have in doing electrocorticography in this kind of patient that have 1 or 2 seizures. And the other comment would be related to hippocampal spiking. I would be very reluctant in removing it because there is spiking, because right now we know that the normal response of the hippocampus to deafferentation, meaning removal of the cortex, is spiking. So, and this can be seen after Amital testing or whatever. You do Amital testing and you increase the spiking on the hippocampus because you remove the action of the cortex. So I would be very reluctant to remove the hippocampus just because it's a spiking post-cortical removal. But maybe we should try to focus the discussion on from my side at the usefulness of intraoperative electrocorticography. Both of you are doing it. I understand that Johan does not take into account its results for guiding the resection, and then you show Eddie appears to give more importance to the ECOG findings to guide the resection, including the fact, for instance, that you show an amygdalar ganglioma and you perform a very large craniotomy with ECOG recording from the frontal parietal and the whole temporal lobe. So maybe could you elaborate on the use of intraoperative electrocorticography, and how would you deal with the proposal of a more image targeted resection for those kind of lesions?
Okay, thank you. Important question. My answer in 3 points. The first reason is that I use electrocorticography in very simple cases. For example, primary surgery, only one seizures, is to learn from this experience, because in recurrent diffuse low-grade glioma, you have more often difficulties to control seizures, and you have possibly more complex epileptogenic networks. So that's, to my opinion, a good way to learn from very basic cases, to have a perfect experience when you require it for complicated cases. In addition, at that time, I tried to accumulate data, as I said, to compute and compare electrophysiological recording to neuropathological findings, because I'm sure, because epileptogenic underlying mechanisms and glioma progression are intermixed, if we are able to identify a neurophysiological signature of epileptic activity, they are all almost systematically in the vicinity of a specific condition of diffuse glioma correlated with the presence of a glioma cell. So I try to obtain a neurophysiological signature to guide the resection to track glioma cells. So that's the way I perform daily electrocorticography to accumulate data on this specific question.
Eddie?
I think Arthur's point is a really good one, which is that it's very uncommon to see patients with refractory epilepsy nowadays, because they do get diagnosed so quickly. There's one condition in which that is not true, which is that when it's near eloquent cortex and the focal motor seizures and language-related focal seizures, and I would say probably a quarter of my practice is patients that were approached initially by an image-based, lesional approach, where they just took out, the MRI finding, and the patient still has ongoing seizures. So I really do think that, most of these patients are referred by this time for refractory seizures, either from near total or total resection of some of these lesions. And so the functional approach, I do think really does have some value. Whether you're going to do with intraop or extraoperative is a different question, but does require some kind of epilepsy approach to it.
I just want to comment additionally that it's fair to say that the meta-analysis that you've shown from Dario in 2011 also showed, I believe, that there was no relationship between seizure freedom or not related to electrocorticography. It did show a relation to extent of resection, but not a relation to the use of intraoperative electrocorticography, as far as I remember the results.
You have a... Sorry, go ahead, Eddie.
Right.
Yeah, to my opinion, this is because in the articles included in this meta-analysis, authors use electrocorticography more frequently in cases with drug-resistant epilepsy, and that possible bias. The second possibility is that it's very difficult to obtain accurate and clinically relevant data from electrocorticography to use in live during resection, but possibly Edouard will elaborate on this meta-analysis.
Bertel?
Yeah, I have one comment and also one question or discussion point. The first comment is that I really like your comment, Johan, about the possibility always to learn from the easy, so-called easy cases. You use a complicated monitoring system to learn from your easy cases. I think that's really great. And then I have a more general comment, and that is, how can we make a patient understand, and that has been discussed, I know, how can we make a patient understand what it is to live with a deficit? Of course, it's a different thing because I don't operate so many low-grade gliomas. I operate mostly dysplasias and things where people usually survive their epilepsy. And in epilepsy surgery, I would never, ever take out the occipital lobe and say to the patient, if I take out the occipital lobe, you get an hemianopia, but you will get seizure-free. No, that is not fair. You may get an hemianopia and seizures, and you may become a double loser. And of course, that is a different thing in a low-grade glioma. Of course it is. Because in a low-grade glioma, you're finally going to die from it, but you're not going to die from a dysplasia. But anyway, I think this is an interesting question, which I just raised right now. Thank you.
Just a couple of comments and questions that we have from attendees, which are linked on areas of technology. So for both Eddie and Johan, how important do you think that intraoperative MRI is in maximizing resection? And on the other side, technology, is there a role for laser ablation in low-grade glioma with epilepsy? And if so, which cases?
Okay, to my opinion, for the intraoperative MRI, that's not a very useful tool because you guide the resection of a diffuse low-grade glioma not based on anatomical extent of the glioma as visible on MRI, but you have to go further beyond MRI abnormalities until eloquent areas. So that's not very useful to my opinion. The first question. The second question, the laser ablation, the focal lesion, whatever the technical principle to treat an infiltrative disease such as diffuse low-grade glioma is not very useful to my opinion. Possibly one may target a particular area posterior, for example, the posterior part of an insular glioma with a remnant in these areas, and can be available and targetable with such a device. That's not very easy technology to develop in the condition of seizure and diffuse low-grade glioma.
And how about for DNETs or gangliogliomas for grade 1?
Yeah, in Santan Hospital for dysplastic lesion, mostly involving the insula with a high risk of deficit induced by the surgical approach. We proposed focal stereotactic lesion to control and destroy the dysplasia and the underlying epileptic network. Yeah, that's a practice we have.
Eddie?
Oh, yeah, Guy, I mean, my thoughts are very similar, which is that if you've got a very aggressive position with intraop mapping, that the intraop MRI is not very helpful. Sometimes there's some context for imaging the medial aspects of the tumor where the tumor boundaries are very, very unclear. But it's definitely not necessary.
So let me ask the corollary on that. Because we know, for instance, people talk about with hemispheric resections where they're most likely to leave tissue behind. So for instance, on a hemispheric disconnection, on the anterior medial frontal disconnection or back by the splenium, people say are the most likely areas to not disconnect. Where are the areas that you two find technically you're most likely to leave residual glioma during for instance, an insular glioma? What are the areas you're most worried about not getting all the tissue just based on surgical technique?
I think the deep subcortical structures like the basal ganglia, thalamus, cortical spinal tract, areas deep to the capsule and the those areas are always. The other area that I tend to find is not very tolerant is the posterior temporal lobe in some of these. Broca's area, I think very often you can be extremely aggressive with resection, including resection of speech arrest area. But Wernicke's, I think, is a different story altogether. So that's just my personal experience.
It's interesting, we talk about this, about extent of resection, and say gross total resection, like all surgeries and all patients are the same. And as we know, Johan, there's a big learning curve on these cases. And so you're always going to want to protect the patient's function. And so what do you think are the most tricky areas with more experience, where you're most likely early on to potentially leave residual tumor in low-grade glioma resection?
In my experience, it is definitely in the insular part of diffuse low-grade glioma, mainly due to areas at risk of vascular damage more than areas with a particular fasciculus. My main fear is the main danger is vascular damage, because I don't control them easily, contrarily to the identification of functional networks. And in the, for example, the inferior frontal fasciculus is protected by the perisylvian tissues that you left behind to prevent any vascular damage. So my main concern is the vascular damages that account for almost 100% of the definite neurocognitive deficit we observed after such a surgery.
Jorge,
Yeah, so I have a question for Ed again. Ed, so based on your experience, I think you have your tumor practice and epilepsy practice, and you have your research related to functional mapping language specifically. So when we stimulate the tumor, the brain associated with a tumor that is not epileptic, it's a different brain than an epileptic brain. But regardless of that, we use the same methods of functional mapping stimulation for tumor and tumor related to epilepsy. But the epileptic brain is different, has a different connectivity. And I wonder, in your experience, in your clinical experience, do you do different methods of stimulation, or you rely more or less to responses when you do a tumor resection not associated with epilepsy versus an epilepsy brain? Because the brain is different, and the response to direct stimulation, it may be different. It may be less specific, like the case that you show when you stimulate and you have the face, the speech arrest, and then you resect it and you did it. You didn't have the clinical consequence of that speech arrest. So in your experience, Ed, do you see differences in response of direct electrical stimulation in the epileptic versus the non-epileptic brain?
I think that's a really important question, Jorge. And I think the short answer is no. I think the short answer is I tend to think about it pretty similarly. Though I agree with you, it's not the same. I tend to treat it the same, but it's not the same. Part of the challenge is how do you really characterize that difference? Like, we know it's different, but then functionally, how is that expressed differently? And one property that's very different, for example, that may be different between epilepsy and tumors is the degree of plasticity, the degree of functionality. So, functioning brain tissue in a tumor is very different than functioning tissue in a not completely non-lesional, type 1 cortical malformation, for example, where you think it might be much more functional in the malformation, but it might not be. So to me, I think the end of the day is that we have to look at each case individually and assess it with all of these tools combined.
Mm-hmm.
But I think as we gather more knowledge, I think your question is very important, is how do we define it? Low-grade associated with epilepsy does, I think, capture both of those a little bit, and the challenge is really how to move beyond just the oncologic approach to incorporate some of the epilepsy surgery principles in it.
Yeah, thank you.
Yeah, Johan, one follow-up question to what you said. You commented at the beginning that IDH1 mutated tumors are mostly what you're talking about with this strategy, but cases don't have a T2 flare mismatch, and it's hard to know ahead of time whether the tumor is truly IDH1 mutated versus an IDH wild type diffusely infiltrating. And at least in my experience, the wild type ones are more likely to potentially spread through function rather than push it aside. And so how do you utilize that in your decision making, your thinking, and do you ever do a biopsy first? So how are you strategizing IDH1 mutant versus IDH wild type tumors, and how does that differ your approach?
Yeah. In my practice, I do not search this information before my surgical strategies. That means that in front of a diffuse glioma on MRI in a patient with an anatomical distribution of the lesion of a neurocognitive status which allows maximal resection, I propose maximal resection directly with no biopsy first. And I do not take into account the very two worlds that are the ADH mutated gliomas versus ADH wild type gliomas. But that's a very important question, and I am currently analyzing my outcomes based on this new classification of the tumors, because for sure they are not the same one and not the same outcomes and not the same need for post-operative adjuvant treatment.
Yeah, I think it's I personally completely agree with you that there's very little role for upfront biopsy, but I think it will be interesting as we see more and more data, how much extent of resection matters in a situation where sometimes there's function in a tumor and you can't remove a portion of it. Eddie, a technical question for you from Olaf Shins, which is you talk about bipolar cortical motor stim and then subcortical monopolar. And so the reason for that, and do you ever do monopolar cortical and subcortical or bipolar both? And can you explain your thinking on why bipolar at the surface and monopolar subcortical?
Yeah, great question and very straightforward answer. So with bipolar, you have very local. So the current is just very focal. It's just between the two probes. With monopolar, you've got one anode and you got cathode, which is basically, or the versed, essentially somewhere else on the head. So monopolar has a much wider field of stimulation. So monopolar is very, very helpful for things like, with monopolar, you can activate motor responses anywhere in the head, depending on the current. And so what's nice about monopolar is the relationship between the stimulation and the distance between where you're stimulating cortical spinal tract. Whereas with bipolar, that's not true. And in fact, when you go up higher currents on the bipolar, you're going to start encountering many other things like inadvertent seizures on higher current amplitudes with the bipolar. So again, the bipolar is a very focal way of probing cortex. You can use monopolar from the cortex, but it's going to be very, very non-specific, meaning that you could stimulate in very far front of the motor cortex at a certain amplitude, and you can evoke movements. But that's primarily because of the spread of the current is much wider with the monopolar. So with the monopolar, it's very nice for subcortical because there's a relationship between the threshold to monopolar stimulation and the distance. Is that helpful?
Johan, what is your practice on stimulation?
First, I have to say that I totally follow the commands of Edward, but my practice, I use only bipolar stimulation probe and bipolar electrical stimulation because I master this technique and I prefer using this technique I master rather than using another one with a less accuracy due to my own practice and lower experience. But I totally follow the fact that bipolar stimulation is more focal than monopolar stimulation. And in the particular situation of deep subcortical identification of primary motor pathway, monopolar stimulation can be very efficient.
And I think it's also, I would think that it's, there are places that do predominantly monopolar and places that do predominantly bipolar and places that integrate them. And I think a lot of it is dependent on your team and what your team's good at and making sure you're doing it well. There is literature that monopolar is less likely to induce seizures at the cortex. And so some people start with monopolar and then maybe use bipolar. But I think if Lorenzo Bella was here, Lorenzo would argue that he thinks that he's more specific with cortical monopolar than he can be with bipolar. And so I think there are experiential differences center to center. You have to do what works for you best at your center also. I think we've had a great discussion and we've tied you guys up for a long time on your Sundays. And so I think it's a good time to wrap it up. So thank both of you for excellent talks and a really great discussion.
Thank you. I'm closing the recording and opening the post-webinar.
Thank you all.
Thank you.
Thank you, everyone.
Thank you both. Thank you.